Hello guys, welcome to SHREE NETRALAYA. This case was a mature intumescent cataract wherein I was supposed to implant a multifocal IOL. I was expecting complications like Argentinian flag sign or a runaway rhexis because of mature intumescent cataract. Surgery started with very usual 2.6 mm main port and a 23 gauge side port. A good trypan blue staining is done. Capsular rhexis started with a cystitome needle and continued till half. Then I noticed that it is difficult to finish off this rhexis with cystitome, so I converted my technique to capsular rhexis forceps. As maneuverability is a bit easier with capsular rhexis forceps, I could manage to finish off continuous capsular rhexis. A hydrodissection with 27 gauge cannula is done and nucleus is rotated as usual. Phacoemulsification started with a power of 50, aspiration rate of 30 and a vacuum of 400 mmHg. I am operating on AMO sovereign compact. I could easily achieve the first job, followed by a rotation of a nucleus and then second and third job. And nuclear pieces are taken out with an ease without much difficulty. Cortical wash is done with coaxial IA probe. Bag is filled with viscoelastic material and an implantation of IOL is followed. As you can notice, I am loading a multifocal IOL in cartridge. There was no difficulty in loading the IOL, or no resistance was felt during push of IOL through the tunnel. So I just pushed the IOL into the tunnel and into the anterior chamber, but noted the trailing haptic is broken at optic haptic junction. I didn't know why it has happened, but probably the rubber plunger has got stuck with a haptic in the tunnel. Anyways, I could notice that this IOL cannot be implanted in a bag as it is a multifocal IOL and decentration can cause a lot of issues to this particular patient. So I was left with only one option of explanting this particular IOL, followed by implantation of a new multifocal IOL. As I noted, the trailing haptic is broken at an optic haptic junction. I did not dial this particular IOL into the bag as decentration is likely in such scenario, which is not acceptable in cases of multifocal IOL. I just took a break of 30 seconds and made my decisions to manage the case further, planned my next steps and proceeded as decided. main port incision and a side port incision is extended a bit to allow easy manipulation and entry of a micro forceps and IOL cutting forceps. So the plan is to deliver this IOL into the AC, followed by a viscoelastic above and below the IOL. A cohesive viscoelastic like sodium hyaluronate is preferred to prevent damage to endothelium and form the bag, and thereby preventing complications of PC rupture or endothelial damage during following maneuvers. In my left hand I am having a micro forceps to stabilize the IOL while cutting it, so that there will be no unnecessary flipping of this IOL which may cause damage to endothelium, iris or a capsular bag. This way you can maintain plane of IOL, which make it easier to cut IOL. Once I have stabilized the IOL in the anterior chamber, my right hand I am having a serrated IOL cutting scissors. You can notice IOL is cut more than 50% of its optic length in a single go without a trouble, as this particular forceps is meant for IOL cutting. It has done its job beautifully. Now I have my IOL cut more than halfway through its optic in anterior chamber. I again formed the anterior chamber with viscoelastic to prevent any touch of endothelium by IOL or otherwise by my microforceps. I use my two microforceps to manipulate this IOL out of anterior chamber. Technique here explained is very well noted in a literature. In this technique, I am going to utilize the uncut area of my optic as hinge and will rotate the IOL through circumference of a optic, thereby explanting the IOL out of a anterior chamber. This particular technique is quite safe, easy to perform, prevent unnecessary too much maneuvering of rotating the IOL 180 degrees to cut it into two halves, and which can cause damage to endothelium and or iris. This IOL cutting scissor is stout with a serrated margins for cutting of a hydrophobic IOL, which is usually a hard material to cut with normal scissors. Hope this case will be helpful to you for any such situation management in future. Thank you for watching. Do subscribe to a YouTube channel Dr. Pankaj Lande for more such videos.